All right, welcome. If you're a new PGY-1, this is for you. We're going to build a practical framework for psychopharmacology. And look, this isn't about just memorizing a list of drugs. It's about really developing a clinical mindset for treating unipolar depression and doing it well. Okay, let's just jump right in with the one number that frames everything we're about to talk about 1/3. That is the percentage of patients with depression who actually achieve full remission on their very first antidepressant. So think about that. For 2 out of every 3 patients you see, your work is really just getting started. So picture this. You're the intern, you're about to walk into the room, the patient is waiting, and they're looking to you for help. It is a moment every single new resident feels. This whole explainer is designed to give you a clear, repeatable process to answer that one fundamental question. Where do I even begin? So, here's our game plan. We're going to walk through the whole clinician's journey. First, we'll nail down our guiding principle. Then, we'll build out your initial toolkit of medications. After that, we'll get into the real art of choosing the right one, what to do when it doesn't work, and finally, we're going to boil it all down to the key takeaways you can use on day 1. All right, section 1. This is where we establish our guiding principle. And it's a huge shift in thinking, really. We're moving beyond just chasing symptoms and learning how to map those symptoms to the underlying neurobiology, to the malfunctioning brain circuits. You've probably heard of this one. The classic monoamine hypothesis is really our foundation. It's the simple, elegant idea that depression comes from a lack of serotonin, norepinephrine, or dopamine. Now, we know it's a lot more complex than that, but this basic idea, it's still the launchpad for pretty much every antidepressant we use today. And here's the modern upgrade to that idea. Today, we think of depression less as just a simple chemical deficit and more as, well, inefficient information processing, a malfunction within specific brain circuits. So our real target isn't just boosting a chemical level, it's restoring the proper function of an entire neural network. So with that in mind, let's build out your pharmacological toolkit. We're going to organize these meds not just by their brand names, but by how they actually work, by their mechanism of action, because that's how we can retune those circuits we were just talking about. First up, the big ones, the SSRIs. These are your most common first-line agents, and their mechanism is actually pretty elegant. They block something called the serotonin transporter, or SERT. You can think of it like a little vacuum or a recycling pump. By blocking it, you stop serotonin from getting sucked back up, which leaves more of it hanging out in the synapse where it can do its job. Okay, but here's the thing. Not all SSRIs are the same. And this is where the art of prescribing really comes in. We don't just pick one randomly. Let's say you have a patient with atypical depression, the kind with super low energy, sleeping all the time. While sertraline has a little bit of weak dopamine action that might give them a nice activating boost. Or what about an older patient on a bunch of other medications? You've got to worry about drug interactions in the liver, right? The CYP450 system? That is where citalopram is fantastic. It's known as the cleanest SSRI because it has so few of those interactions. And for a patient you're worried might miss a few doses, fluoxetine's incredibly long half-life is a lifesaver. It basically tapers itself, which really cuts down on withdrawal symptoms. Now, this brings us to the next logical step. What if serotonin alone isn't cutting it? Or what if your patient's depression also comes with a ton of fatigue or even chronic physical pain? That's when we bring in the SNRIs. By adding norepinephrine reuptake inhibition, we're now hitting a second critical system that's involved in energy, focus, and even the body's own pain-dampening pathways. And beyond those classics, your toolkit has some really cool specialists, the atypicals. Bupropion is an NDRI, and it's fantastic for patients with that deep anhedonia, that inability to feel pleasure, or for anyone worried about sexual side effects. Then there's mirtazapine, which is just fascinating. It's super sedating and can crank up appetite, which sounds like a bug, but it's actually a feature if your patient is agitated, can't sleep, and has lost a bunch of weight. And trazodone, at low doses, it becomes a highly targeted tool just for insomnia. Okay, so we have our toolkit. We've got the SSRIs, the SNRIs, the atypicals. But how does this go from being just a list of drugs to a repeatable clinical process you can use with every single patient? Let's get into it. It really all comes down to a structured thought process. It's 4 steps. 1. Identify the patient's absolute worst, most debilitating symptoms. 2. Match a medication's mechanism to those specific symptoms. 3. You have to consider the whole person, their other medical problems, what side effects they're terrified of. And finally, number 4, the one we can never forget, monitor, monitor, monitor. Prescribing isn't a one-and-done thing. It's a dynamic process, a partnership with your patient. But what about those two-thirds of patients we talked about at the very beginning? What happens when your thoughtful, well-chosen first-line medication just isn't enough? Well, this is where skilled psychopharmacology really shines. This exact scenario is going to happen to you all the time. Your patient's on an SSRI, they feel maybe 50% better, but they're still stuck, they're still struggling. And they're going to look at you and ask, okay, doc, what's next? You need to have a plan. And the good news is, you have several evidence-based options. You can augment with an atypical antipsychotic like aripiprazole, which brings a whole new mechanism, dopamine modulation, into the mix. Adding bupropion can be an amazing move to tackle that leftover fatigue or anhedonia. You could even use L-methylfolate, which is basically giving the brain the raw building blocks it needs to make neurotransmitters. Or you can turn to a classic like lithium, which is still a powerhouse strategy. Now, for those really tough treatment-refractory cases, here's a clinical pearl that you have to remember. It's the combination of an SNRI plus mirtazapine, a combo so powerful it has the nickname California Rocket Fuel. And here's why it works. The SNRI is blocking the reuptake pumps, right? At the same time, mirtazapine is basically cutting the brakes on serotonin and norepinephrine release. You're hitting the system from two totally different angles, creating this incredible synergistic antidepressant effect. So after that whirlwind tour, let's just boil it all down. What's the core mental model you can take with you onto the wards tomorrow? If you remember only one single thing from this entire explainer, please make it this. Think circuits, not just chemicals. Your job is to listen to the patient's story, identify their symptoms, map those symptoms to a malfunctioning brain circuit, and then choose the right pharmacological tool to fix that circuit. That's the whole game. And so we end here. This is the question that should guide every prescription you write. Your goal isn't just to give someone a pill, it's to restore function, to fix a circuit, to give them their life back. So go back to that patient waiting in the room. You have a framework now. How are you going to choose your first tool?